Hi, I'm Diana North. I'm a general practitioner and I also work for the Goodfellow Unit. Today we're talking about the topical management of non-melanoma skin lesions. And we're lucky enough to have here today David Lim, who is a dermatologist who works for the Skin Institute. Hi David.
G'day, great to be here.
As a GP, I see so many sun-damaged skins. Usually I'm asked at the end of a consultation, can you just check this spot for me? And I have to say, I thought I was pretty good at it until I started researching for this talk and I looked at more and more pictures.
Yep.
And I'm feeling a little less secure now than I did when I started. So I thought maybe we could just go through the basics again.
So I'll start with actinic keratoses. These are precancerous lesions that do have the potential to develop into invasive squamous cell carcinomas. So these are usually small, superficial, scaly lesions that present in areas of skin that have had chronic sun damage. They can either present as solitary spots or they can have multiple in an area, what we refer to as actinic field damage.
Now you're saying they can become cancerous. What sort of rate do they become cancerous?
Studies have shown that this is anywhere between 10 and 20% per year.
What about the basal cell cancers?
Yeah, so basal cell carcinomas are the most common invasive skin cancer. Now these are rarely life-threatening, but they can cause significant morbidity if they're not treated appropriately and they invade surrounding structures.
Talk me through the different types that I might see.
There are many different types of basal cell carcinomas, but there are a few very common ones. So nodular basal cell carcinomas are the most common. They typically present as a pearly nodule and can often have central ulceration.
What other types are there?
So the superficial basal cell carcinomas are also quite common. They're typically a flat pink patch with a subtle translucent rolled edge. Sometimes they can have small areas of ulceration throughout the lesion.
So what about the squamous cell cancers?
Actinic keratoses are precancerous lesions. They can potentially develop into invasive squamous cell carcinomas. The invasive squamous cell carcinomas, they usually present as nodular scaly lesions with some induration into the skin. And the squamous cell carcinoma in situ, they tend to be in between the two. So they can look like actinic keratoses, but tend to be over a broader base with a bit of red. The
thing that struck me is that we often actually probably do need to biopsy to know what we are dealing with.
Yes.
Let's talk through biopsying. Who should I biopsy?
The key to biopsy is to biopsy when you're unsure of the diagnosis. Often lesions are treated inappropriately by non-surgical methods when really they do need to be excised formally. So it is important to biopsy these lesions, not just to get the diagnosis, but also to work out the depth, which can guide whether surgical treatments are required or whether non-invasive treatments are appropriate.
So David, what is the best way for us to biopsy non-melanoma lesions in general practice?
The best way to perform a biopsy on a non-melanoma skin cancer is a 3 to 4 millimetre punch biopsy through the middle of the lesion. This allows a good sample of the worst part of the lesion as well as an assessment of depth. I routinely stitch punch biopsies to improve hemostasis and cosmetic outcome.
I'm seeing more and more shave biopsies coming back from dermatologists. Can you talk to me about that? How are they done?
We typically do shave excisions or biopsies for the cosmetic removal of some lesions such as seborrheic keratoses. Now these lesions are typically very superficial, so they're quite amenable to a shave excision or biopsy. We use an instrument called the Biopsy blade, which does have a safety handle around a flexible blade. We slide the blade over the skin and insert it into the skin superficially. It's always a trade-off between clearing the lesion as well as keeping it superficial enough so as to not cause a large depressed scar.
Is there any role of the shave biopsy for helping us diagnose basal cell cancers or squamous cell cancers?
We tend not to do shave biopsies. The punch biopsy is going to give you a better diagnosis and a better assessment of the architecture and depth of the skin cancer.
Today we're actually focusing on responsible prescribing and using the topical treatments for non-melanoma skin cancers. And I guess we're talking a little bit, we all use liquid nitrogen, but it's about 5-fluorouracil, which is Effudix in New Zealand at present, or imiquimod, which is Aldara.
Correct.
Tell me a little bit more about them.
The 5-fluorouracil, or the Effudix cream, that's actually an anti-metabolite medication. What happens is that the cell takes up the cream and it impairs RNA and DNA replication, and when that is blocked, the cell dies off. Cancerous cells or dysplastic cells tend to be more vulnerable to the Effudix cream.
What about the imiquimod? How does that work?
So the imiquimod is an immune system modifier. It tends to activate the immune system and encourages it to fight off the skin cancer.
How do I know what to use?
The fluorouracil cream is appropriate to use on actinic keratoses. Typically we use them on the areas where there's extensive actinic damage, or what we refer to as the actinic field damage. In certain situations it can be used for squamous cell carcinoma in situ. Now, surgery is still considered the first-line treatment for the SCC in situ. However, in those patients that refuse surgery or in areas where it might be considered inappropriate to do so, then fluorouracil is a treatment option.
What about the imiquimod? When should I use that?
Yeah, so the imiquimod cream is typically used for superficial basal cell carcinoma. However, again, surgery is still considered the first-line treatment for superficial basal cells carcinomas. However, again, in certain situations it may be appropriate to use the imiquimod cream.
So what I'm really hearing is that surgery is pivotal.
I mean, it is still considered the first-line treatment, and the creams are useful in situations where that's not possible.
What kind of things might stop us doing surgery?
Situations include, patient factors such as, frail, elderly patients who really just don't want to go through surgery. It may be appropriate to use the fluorouracil cream, but again, ideally just on the superficial lesions. There have been studies that have shown that these topical creams can really only penetrate down to about 0.4 millimetres in the skin. So really just lesions that are affecting the epidermis.
Right.
Okay. The problem is if they are used inappropriately on invasive cancers, it's just not going to get rid of the lesion. So it might tidy up the surface of the skin, but you may still have the cancer growing hidden under the surface of the skin.
Do you have any hot tips on how to tell if it's superficial versus invasive?
Yeah, we'll get back to that squeeze test. Palpation is a key tool in dermatology. So you feel the lesion. If there's no induration, there's no thickness to the skin underneath the lesion, then it is most likely superficial and just in the epidermal layers.
What advice would you give general practitioners to prescribe imiquimod and 5-fluorouracil safely in general practice?
So again, getting back to the key, you need to be confident about your diagnosis, and when in doubt, either do a biopsy or get a second opinion. Okay. For the fluorouracil cream, I usually prescribe that to be used once a day in the evening. And the duration of treatment does depend on patient response, but also the area of the body. Now,
Right.
typically, I usually say for about 2 weeks on the face, okay, about 4 weeks on the scalp, arms and body, and about 6 weeks on the legs.
Let's go to Imiquimod. How do you prescribe that?
I usually prescribe it to be used once a day, 5 days a week. The easy way to remember that is just use it on the weekdays and then take a break over the weekend. Again, the duration of treatment does depend on the location of the body, but usually between 4 and 6 weeks of duration.
Are there any risks or side effects we should talk to patients about Imiquimod and 5-fluorouracil?
It is expected that the fluorouracil cream will cause an inflammatory reaction, and this can even lead to blistering in some situations. I always try and warn patients about this and advise them that it's actually a good thing because it means the cream is working. And I do this partly to warn them, but also to help with the compliance and give them some motivation to continue through the treatment. Now, unfortunately, this can be quite uncomfortable for some patients, so I do routinely prescribe a mild steroid cream that they can use to take the edge off the discomfort. Now, normally I'd give them some triamcinolone cream and I'd say to use this once a day in the morning when they need to take the edge off it, and they can continue with the fluorouracil cream at night. In situations where it becomes very uncomfortable, patients can actually take a break from treatment for a couple of days and then resume again once things have improved after about 3 or 4 days, and then continue on with the treatment.
Do you get the same reaction with Imiquimod?
Yes, so Imiquimod can cause a inflammatory reaction as well, and can also cause significant blistering. Another side effect of Imiquimod is that it can actually cause a flu-like illness or symptoms, and this is because it is an immune sensitizer and it's activating this immune system, and so people can actually get a systemic reaction, although this is uncommon.
If patients are experiencing those flu-like symptoms, is that a reason for us to stop the treatment with Imiquimod?
Not necessarily. It comes down to how the patient is coping. If they're not too bad, it's fine to continue with the treatment, but if they are struggling, it might be a good idea to take a break for a few days and then resume treatment once things have settled down.
I often see people with actinic keratoses. Talk to me a little bit more about liquid nitrogen.
Yeah, so liquid nitrogen is a good, convenient and cheap treatment. It is appropriate to use on actinic keratoses. Normally, if there's a few isolated actinic keratoses, this is when I would use cryotherapy. However, when there's more actinic field damage, this is when I tend to move towards the field treatments such as the fluorouracil cream and the photodynamic therapy. Now, it is fine to treat these extensive areas with cryotherapy, but I find it is a bit cruel on the patient because it can be quite uncomfortable.
Can you tell me a little bit more about photodynamic therapy?
Photodynamic therapy is a treatment that is done by a doctor or a nurse. The patient comes into the clinic, the area of treatment is identified, and a special light sensitizing cream is applied to the treatment area. Now, there's an incubation period anywhere between 1 hour and 4 hours for when this cream is left. And then after the cream is incubated, a special light source is applied to the area, and it works in a similar way to the fluorouracil cream. It kills off these abnormal cells. Now, there are quite a few benefits to photodynamic therapy. One is that it's usually either a one-off or sometimes 2 treatments. There's a shorter recovery period, and it does actually have superior cosmetic benefits. Unfortunately, it is expensive. It's normally only available in either private practices, but occasionally is available in some public hospitals as well.
I'm going to ask you a tricky question. Are there any things that you see in your specialist surgery that concerns you about the way we're managing these lesions at present?
Unfortunately, these lesions that are treated first with cryotherapy and then recur have a much higher complication rate, much higher recurrence rate, and it's basically much more difficult to cut these lesions out. Patients have the best chance for getting rid of a skin cancer with their first treatment, regardless of what that is. Unfortunately, we've seen many cases where lesions are inappropriately treated with cryotherapy over and over again, and then years later we end up with these disaster cases and having to have extensive surgery. So a lot of morbidity that the patient experiences, such as nerve involvement and structures, local structures are compromised.
So what you're saying is, if I know or believe it is an actinic keratosis, it's okay to liquid nitrogen?
Yes.
But with these other lesions, early BCC, superficial squamous, the risks are so much greater if I do freeze them and then get a recurrence.
Yes. As I mentioned, it's best to cut it out first. That's the first line treatment, and rather than just give it a freeze and see what happens.
We've got liquid nitrogen cryotherapy, we've got the local creams, imiquimod, and we've also got 5-fluorouracil, and we've got PDT, photodynamic therapy.
Sure.
There's a role for each of these. It's about knowing when and how to use them. What hot tips do you have to help us make the right decisions?
So I would say solitary actinic keratoses, you're looking at cryotherapy normally. If there's a concern about scarring and hyperpigmentation, then I would consider the fluorouracil cream. When there's actinic field damage, so this is several actinic keratoses within an area, then we do need to look at field treatments to be kinder to the patients. And again, these treatments include the fluorouracil cream and the photodynamic therapy. The trade-off here is between cost and convenience for the patient, but the photodynamic therapy does have the superior cosmetic outcome as well. So with the superficial basal cell carcinomas, the first line treatment is still surgery, but when surgery is declined or inappropriate, that's when you can use the imiquimod cream. With squamous cell carcinoma in situ, the first line treatment again is surgical excision, but fluorouracil cream is an option for patients that decline surgery or where it's considered to be inappropriate.
When should we be concerned about whether we should refer to a specialist for surgery versus attempting to remove the lesions ourselves?
There are areas that are considered high-risk sites. So this is the H zone on the face, which involves the ears, the area around the eyes, nose and mouth. These areas do have a much higher rate of recurrence and spread to regional lymph nodes. These are areas which I would consider should be referred on for specialist surgery, including the Mohs surgery. Referral should also be considered for high-risk lesions. Now these include large lesions, lesions which are rapidly growing, as well as high-risk features found on biopsy, including poor and moderate differentiation, as well as perineural invasion.
Well, it's been fantastic talking to you today, David. Do you want to leave me with 3 hot tips for my colleagues to help us with the management of non-melanoma lesions in general practice?
First thing I would have to mention is be confident about the diagnosis. If you're unsure, either get a second opinion or perform a biopsy. Secondly, remember that surgery is still the first line treatment for skin cancers, and I'd actually recommend using a dermatoscope to mark out your surgical margin if you're going to perform the surgery. Thirdly, most surgery should be considered for recurrent or high-risk lesions as well as cosmetically sensitive areas.
In general practice, we are going to see more and more sun-damaged skin. With the ageing population, we need to be very competent at both our diagnosis and treatment of non-melanoma skin cancers. The responsible prescribing and use of imiquimod and 5-fluorouracil is increasingly important, as we can now use it without needing to get a special authority. But I guess the bottom line for me is that for the treatment of non-melanoma skin cancers, the primary treatment is surgical, and that we need to remember that rather than risk our patients being exposed to further damage from these lesions.